Hello, and welcome to the show Beyond the Journal, where we discuss social media, digital education, and current controversies in cancer and medicine. I'm Dr. Jack West, Associate Clinical Professor in Medical Oncology at the City of Hope Cancer Center in the Los Angeles area. And I'm joined today by my co-host, Dr. Charu Aggarwal, who is the Leslie M. Heisler Associate Professor of Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center in Philadelphia. Hey, Charu, how are you?
Hey, Jack. I'm good. How are you?
Good.
So today we are pleased to welcome Dr. Sam Mullangi, who is a physician with a degree from the Harvard Business School, an MBA, and now a hematology oncology fellow at Memorial Sloan-Kettering Cancer Institute in New York, and lead author of a recent publication in JAMA Internal Medicine on opportunities to revise state medical licensing requirements in the wake of the COVID-19 pandemic. Welcome to Beyond the Journal.
So glad to be here. Thank you for having me.
Excellent. So let's start just with a little background. And before starting your fellowship last year, I think were thrown into the deep end, I imagine, by working as a hospitalist in the New York City area during the pandemic. I'm sure there's tons to talk about with that, but can you just introduce us a bit on the experience and some leading points of coming from that background, both with a business background, healthcare policy, and then being on the front lines as you were for this?
Yeah, so just to make it clear for our listeners, so before I started fellowship here at MSK, I was a hospitalist for 2 years at Cornell, affiliated with York-Presbyterian Hospital. And I was winding down my tenure there, kind of leading into fellowship when COVID happened. So New York recorded its first COVID case on March 1st, and I think within a month had 10% of the world's cases. And I had a front row seat to those early experiences, and it was all very surreal. So when we went into lockdown, I could, on my daily walks into the hospital, see Manhattan being this entirely surreal ghost town. And even the hospital, which really, often thrums with activity, felt like this abandoned railway station. We had converted 7 different floors into COVID-19 floors and stood up at least 4 new ICUs. And as a hospitalist, I was staffing one of the new ICUs at night. And I cannot emphasize enough how strange it was to go from managing patients with, a variety of conditions and acuities to all of a sudden treating the exact same thing, same set of issues, patients struggling to breathe, always alone, never with their families, getting the same cocktail of meds, and going through the same social complexities on a day-to-day basis. I guess from a management standpoint, there were a lot of things that I would say that my hospital medicine chief did really, really well, and I'd love to highlight them, especially relative to, I think, what we were hearing from other institutions. So every morning, for example, he would send out an email that summarized our patient volume statistics, our state of PPE supply, guidance on how we could stretch that supply, always had a summary of evolving information. If we had new clinical protocols, new trials that were opening, that was front and center. We always knew exactly how to manage our patients. And he always actually, at the end of those emails, he would include a whole list of references. So for the academics around, it was always lovely to see that. And I can't tell you how much we appreciated those daily communications at a time, I think, when physicians around the country were really voicing their discontent, with what they perceive to be out of touch hospital administrators, which, would potentially create an us versus them attitude. We felt like our medicine chief really led from a point of transparency and community. We're kind of saying that again now in New York with Cuomo and the nursing home fiasco. I really think that in a crisis, trust in leadership is everything. Another thing that I think New York Presbyterian really did well by or did right by, I would say, its frontline workforce is that they aligned with us monetarily. So, elsewhere, again, we were hearing about furloughs and pay cuts. And NYP was one of the few health systems that actually delivered on hazard pay to folks at every level, from house staff to the attendings. And, honestly, I don't have insight into what non-medical workforce, how they, potentially fared in this whole process, but I would have to assume that they were also part of it. I think in the short term, you would argue that this is a decision that could have deepened, the hospital system's financial woes. But honestly, I think morally it was the right thing, and it probably prompted loyalty and longer term may have reduced turnover, at a pretty volatile time.
But one of the other big issues with there were huge issues with the pandemic, throughout all of society and medicine. But on the front lines, you were also dealing with patients who were getting very sick, probably had restrictions, almost certainly on, visitors coming in. And if you're managing patients in an ICU or have life-threatening illnesses, you were dealing with trying to communicate with family about these high stakes issues, about code status and goals of care, and patients who were dying, but you couldn't have them at the bedside. And telemedicine kind of got thrust onto the scene by necessity. Can you talk about how well that worked, or what needed to change? Because, telemedicine, we've always had the software and the hardware maybe to do it, but it was a tiny fraction of how we did medicine until March of last year. So, what was that like, and what needed to change in the system to make it happen?
Yeah, so I think there's probably a distinction that I would draw between the telemedicine that I was using in those early days of the pandemic as a hospitalist, and probably the broader use case of it in the ambulatory setting. As a hospitalist, actually, we piloted, and I think ultimately this wasn't as successful as we hoped it would be, but we piloted what we called a virtual hospitalist, where, because, I think, in those early days, we weren't even really 100%, we didn't have 100% clarity on the transmission. And we, for example, were very worried about fomites and whether or not the virus could stick to, like a pen and paper or phone in the room. And so we would, at NYP, we had this pilot where we would call another hospitalist on the phone, put her on speakerphone, put her in the pocket, go into the patient's room, and then have an entire conversation with the patient, hands free, not writing down anything or touching any devices. And the hospitalist in your pocket was the one who was looking stuff up for us and communicating. It was so, it was just something that you put together, assemble together a solution in the middle of a crisis. But, I think the bigger use case, as you alluded to, is probably in the ambulatory setting. And that, I think, has really taken off in such a wonderful way. And now that I'm a fellow at MSK and, almost entirely ambulatory, you can really see what a value add it is for patients.
But speaking of, telemedicine, especially in oncology, I think it's been a big advantage to us, especially during the pandemic, where we've been able to seamlessly integrate telemedicine. And frankly, patients really like the opportunity to have family members with them in this telemedicine visit, have, siblings or children join them from different parts of the world, sometime even to, sort of drop in and listen in. And it's been really fantastic. However, it has also really made clear that, there are many requirements that have been broken in the U.S. Medical licensing system, which are just now coming to the surface very clearly in the face of the pandemic. And you talk about this in your recent article, but also earlier in terms of, opportunities that COVID-19 may provide with telemedicine. Can you briefly speak about how these medical licensing requirements have been set historically, and how they have emerged during the pandemic?
Yeah, so the medical licensing process, has its roots in, I think, a very different society and during a time in which medicine was practiced very differently. So the system really arose and expanded in response to, I think, the prevailing medical knowledge and technology at the time. So really, when this country was established in colonial times, state regulation of healthcare really made sense. I mean, at the time, the big medical issues were really these infectious disease outbreaks in the colonies, and having a local response for both monitoring and quickly responding made sense. It required local knowledge. It required a very focused response. And so the very first regulatory initiatives back in the day were actually mainly municipal initiatives. The very first hospital in the country that was established by the city of Philadelphia, your hospital. And so a lot of medical practice was really at that time also not very standardized and frankly pretty questionable. So, we've heard about things like bleeding and purging. I mean, so there was honestly, it made sense at the time that physicians should be regulated by local medical boards comprised of their peers, analogous to, I think, local guilds in other industries. And each state now has the authority to regulate health professionals who practice in their own territories. They each have a version of the Medical Practice Act, which is created and enacted by their state's legislature to govern the practice of medicine. And it goes back to an 1889 Supreme Court case that said that was in the state's best interest. And they delegate their regulatory authority to a state medical board. And honestly, all of these state statutes, even though they're all independently written and enacted, all have honestly very small variations between them. And so the legacy framework makes less sense today. I think when the medical practice that we all practice is very, very standardized. And two, we have new technologies that really stretch, our reach beyond local communities. So namely through telehealth. During the pandemic, there was a recognition that this legacy framework was pretty outdated in response to that burgeoning crisis. So, during the pandemic, states recognized that they both needed an influx of on-the-ground physicians, such as emergency physicians, hospitalists, critical care physicians, but they also needed to solve for those specialists who care for patients in other states and who could no longer, these patients could no longer travel for in-person care. So a lot of states waived these requirements and allowed professionals who were licensed out of state to allow them to provide services in state. And some states also extended this reciprocity for the provision of telemedicine, but actually not all, which is stunning. So at MSK, for example, I remember being on the melanoma service recently with Dr. Posto and seeing a piece of paper taped on his wall behind his desk that referenced which states he could legally conduct a telemedicine visit with and which he couldn't. And that list would update weekly, and it was just so clumsy to keep up with. And honestly, frankly, I think it hurts patients.
Yeah, but it seems to me that this legacy system, there's a lot that by necessity has changed since colonial times. But for this, it has persisted, to me, it seems, mostly for revenue collection. It's a lot of money. I believe I read that California, where I am, gets $62 million a year in medical licensing fees. And at the same time, there's certainly states that benefit from being protectionist for their local physicians, so that, to protect against the patients within that state potentially getting specialist care elsewhere, but at least working in the local interests of the physicians to the detriment of the patients. Is there any really good practical aspect of the system we have, or did the rollback of these rules essentially come in the face of this becoming completely indefensible because there's no good that comes of it? Am I being too harsh?
Yeah, so I think it can certainly seem that way, right? But I think there are a few advantages to the state-run system that any proposed reform should take into, careful consideration. There's no question, I will say, that state-based medical licensing is way more complex than it really needs to be. And in many non-unionized spaces, there's been a move away from this upfront regulation towards more of market correction. So for example, if somebody were to sign up to be an Uber driver or something, they probably get signed up with pretty perfunctory initial processing and then only be shown the door if they were to be racking up like really poor consumer ratings. And of course, we cannot be so blasé in medicine. The stakes are higher and the needs for consumer protection are just that much more intense. But this is the argument that proponents for the status quo continually put forth, that, state-based medical licensing is inherently linked to state-based consumer protection with oversight by state licensing boards and the recourse of malpractice litigation through the courts. So that is one thing that, I think in any kind of reform where we allow, widespread, like cross-geography telehealth is something that we should keep in mind.
But the reality, I'm sorry, just to follow up, you did mention that these systems are extremely similar from one state to another. So, if I drive from California to Arizona or Oregon, my driver's license is reciprocal. And the requirements that Charu has if she moves to California or I move to, Pennsylvania or New York are going to be honored. And yet we just have this system that is a temple of inefficiency in requiring extra processing. I think that's part of the frustration.
Yeah, there's a lot of redundancy and a lot of overlap. And it's not just, the state level that's kind of keeping an eye on physicians and malpractice and disciplinary actions, but it's also hospitals that offer credentialing. It's insurers that, that physicians will ultimately send their claims to. It's a whole host of private companies that do this. So there's a ton of overlap in these functions. So you're right.
Having practiced in New York now as an ambulatory physician and also having lived through the pandemic, can you speak to some of the changes that you've seen that have been implemented? And also, I think, you've had some thought-provoking ideas about what changes can be implemented, our sort of learnings from the pandemic. So could you talk about both of those?
Yeah, absolutely. I mean, I think being in New York offers a really great vantage point to comment on all of this. So, early in the pandemic, we saw thousands of nurses and physicians come into the state to help on the ground as a result of these policy changes and waivers that happened. And the ambulatory side obviously would have been bereft if not for telemedicine, and we know that too. I read somewhere recently that in an analysis of just commercially insured patients and Medicare Advantage patients, that the pandemic saw a 2,000% increase in virtual visits in the first 6 months of last year. But this increase obviously unveiled this major limitation of state licensure. So, an out-of-state patient can be seen in a physician's office, but that same physician can't have a virtual visit with the same out-of-state patient. And especially here in New York, we have a lot of patients who live by the state border, right? So folks who live in New Jersey and Connecticut routinely come in to get their care here at MSK. And so existing state licensing requirements had to be waived in order for us to continue caring for these patients who are already established here, but just via this virtual mechanism. Yeah.
And then, so what about the potential fixes for this on a sustained basis, not just crisis pandemic measures?
You want me to just propose the ideas that we put forward in the paper?
Yeah, both. What are some of the possibilities, and what do you see as the most viable paths forward?
Okay, sure. So, the obvious solution that I think initially comes to mind to a lot of people is, why do we even have the state-based licensing thing? Why don't we just get rid of it altogether and just have this national system in place? And for a variety of reasons that we could potentially get into if you'd want, but my co-authors and I just felt that was not going to be politically feasible, that states would be very loath to give up that responsibility and, as you said, the revenue stream. So we proposed, what we think of as kind of a middle ground. So we proposed 3 solutions that bring a little bit of portability into the licensure system, but without fully mixing the role of states. So the first one is to define telemedicine as interstate commerce. So in our first solution, we say that Congress should regulate telemedicine across state lines as interstate commerce, and that is their jurisdiction. The way they could do that, we felt, was establish the place of service of a telehealth visit as the location of the clinician delivering care and not the location of the patient, which is how it's currently viewed. So as long as physicians are licensed in the state from which they are delivering care, so if I'm in New York and seeing somebody in New Jersey, as long as I'm licensed by New York, that I would be able to conduct that telehealth visit. And like I said earlier, this would have to be, mapped alongside like a system of consumer protection. So if there were to be, some issue that comes up, negligence or malpractice or whatever, that New Jersey can be assured that New York will take action against me as opposed to protecting me. So again, that would be a congressional action. Congress would have to say that a physician's home state medical board would be responsible for any disciplinary investigations, and that New Jersey would have to honor that. The second solution that we proposed was expanding what's called the Interstate Medical Licensure Compact, or the IMLC for short. This is something that was established in 2014. It's basically a legally binding agreement between participating states, and right now about 26 states are participating, that agree to adopt uniform standards for licensure. So basically, if a physician, if I were to designate New York as sort of my state of principal license, and I've been found to be eligible by New York State Medical Board, then I can apply for expedited licenses in other in other member states. So the IMLC just provides a mechanism for other states to vet or to basically mutually recognize these vetting processes, but they're not. I will distinguish, they're not actually recognizing the license itself. They're just recognizing the vetting process. What it would do is it would streamline the whole process of applying for multiple state licenses, but it doesn't actually take away from the fact that you'd have to pay for multiple licenses. So it literally just, I think, frees up this administrative hassle. And in our paper, we say that the IMLC should go further and mimic its nursing counterpart and Inspiration, which is the Nurse Licensure Compact, which actually goes one step further and allows for full license reciprocity between states. And the third idea that we suggested was to encourage and increase adoption of telehealth specific medical licenses. So this is something that's not necessarily a new idea. The Federation of State Medical Boards had proposed like a special purpose license for the express practice of telemedicine way back in 1996, but uptake has been very limited. So at present, just a handful of state boards will even issue these telehealth specific licenses, and some of them will only do it if the other state that you're seeking the license for offers reciprocity. And honestly, I don't even have numbers on what the volume of these telehealth specific licenses are, like how many of these are being issued and used. So I think it's something that would, it's a solution that would require adoption by individual states, but similar to honestly the IMLC, with both of these, Congress can encourage it. They can offer incentives to encourage adoption, whether that's increased funding for public health, increased funding for graduate medical education, et cetera, et cetera. Well, among these options, which one is most feasible? I think probably the expansion of the IMLC. Yeah. It's a construct that already exists. Already half of states are participating in it. What can we do to encourage further adoption? So obviously the federal government, because it's an agreement, it can't actually require states to join the compact, but it can encourage it and it can speed up the process. So it can, put into a framework for, like how consumer protections would flow, guidance on what the fee structure should look like, guidance on handling physician malpractice. So those are all things that I think, at a federal level, we can put into place to encourage and allow states to, participate in this. Yeah,
because I think I'd seen that, Congress was moving toward penalizing states for not participating, or rewarding states for doing so, but certainly can encourage with funds to bestow or withhold to a state, depending on how welcoming they are of playing well with others.
Exactly.
Yeah.
There has been a difference in institutional response to the adoption of telehealth. I think one of the benefits of COVID has been adoption of telehealth. And of course, we have some challenges. But there has been, differences because of variable in level of investment in technology. What do you think are some ways maybe to incentivize telemedicine in the future and therefore the much needed investment in technology?
Yeah, I mean, so telemedicine adoption really did happen overnight, right? With health systems kind of collaborating together whatever was available and getting their clinicians online. A few important policy changes at that time did ease that transition. So one was the previous administration issued these waivers around, they basically relaxed the restrictions around telehealth reimbursement. So now we have pay parity. They issued waivers around where you could provide telehealth. So now patients don't have to be in like a rural or a health shortage area. They can get telemedicine access at wherever they are at their home. And also HHS's Office of Civil Rights waived penalties for any HIPAA violations during the pandemic, because providers sometimes were having to resort to using things like FaceTime or Skype, and they didn't have access to the latest and greatest telemedicine technologies. And so all of these waivers were put into place, and those were very helpful. I think some of these waivers should continue. So I think pay parity for telemedicine, or as close to it as possible, should continue. I know what your experience is, but here at MSK, I feel like a telemedicine visit will take just as much time on the part of the provider as an in-person visit. You're covering the same, content, and it takes time. And actually, I would say that with folks, with varying levels of health literacy, getting online sometimes takes even longer than an in-person visit. I think waivers for a patient's location should continue. The question around HIPAA, I think, is beyond, the scope of like my knowledge, but I'll leave that to the lawyers. The other thing is that in terms of like funding, so the CARES Act in 2020, I think allocated something like $200 or more million to help provide telehealth services at critical access sites. So like rural hospitals or federally qualified health centers. I think, they definitely are first in line in terms of getting funding and getting help with their infrastructure set up. But when the current tension of the moment lifts, I think it would be good to take a minute and, take stock of what's been implemented so far and how physicians and patients are faring, because I think there's a wide variability.
Yeah, I agree. I also think, it'll be important to, recognize that what's been done so far was kind of just throwing everyone in the deep end in a not necessarily optimized way, that the user interfaces weren't all great and people had no real background often in doing this, and that's all going to get better. But it was a kind of a rush job, and I think it will remain to be seen how much people, both docs and patients, want to do this as a fraction of their clinical path. I think it's wonderful for a subset of patients who are more stable, on oral therapies and just need to be checked on every couple or 3 months to review scans, and particularly if they're tech adept, they're comfortable with that, and it would take them half a day to go visit you at MSK and then turn around and come back, versus being able to hop on a call, a HIPAA compliant or otherwise optimized video discussion of the same kind of thing that you'd have locally. So do you have thoughts, and you have some of your own personal perspective and all these other people you're encountering about how well accepted this is for patients, for docs? I mean, my sense is it's extremely variable in both, and some really like it, some patients, some docs, some would only use it as a last resort and can't wait to stop doing it as soon as they don't have to. Where do you see telemedicine landing once it's not of necessity?
Yeah, I mean, so I think you exactly nailed it on the head, which is that there's we again want to make a distinction between patient preference, whether or not they prefer to be seen in a quick telemedicine visit, or whether they really like that, doctor's touch in person, and also the inability, right? Like some folks just can't, they don't do well on telemedicine. It's for a variety of reasons. They might not have the right technology. They might not have the right health literacy or the, ability to navigate technology. And sometimes they don't even have access to broadband, internet access. And so I think I read recently that New York City alone, for example, we are such a dense city, 99.9% broadband coverage, and a third of our households don't have a subscription to broadband for their homes. And that comes to something like 2 million residents. And so if that's the case here in the city, I mean, I can only imagine that it's that much worse out in, the rest of the country. So I think, in my experience here at MSK, I've seen just like the whole spectrum of it. Like I've seen patients absolutely love it, especially the ones who, because we are a big referral center, we have folks who are really driving and flying across the country to get here. They love it. They love being able to just get their second opinion or the blessing on how their treatment's going or whatever it is via telemedicine. But then we just have a lot of patients who really struggle trying to get online. And it's like, spend 10 minutes, a visit, just trying to coach them on, do you see me? Do you hear me? All I see right now is your elbow. Can you adjust the phone? Right. And so I think there has to be a two-way, conversation that happens around health literacy and making sure that the right people are being offered this, but also that everybody else is kind of brought up to like a reasonable standard.
I think you raise a very good point. At Penn, I see a very diverse patient panel. I very much see patients that are technically adept and are able to log on to any basically platform that I offer them. And then, the inner city population who are clearly just not equipped for telemedicine. Do you think we are now creating a new disparity, the so-called digital divide? And how should we as physicians or oncologists prepare for a future where there is equitable care delivery? And, what can be some policies, in line with making sure or ensuring that, we're treating all patients the same way?
Yeah, absolutely. I mean, I think with the digital divide, it's something that impacts folks who are elderly, who have low levels of health literacy, low socioeconomic status. And so I think that's something that we should be very cautious about moving forward and, not to curtail our progress in telemedicine adoption because of health equity issues, but also to recognize them, and constantly address them along the way. I think any path forward would have to take the form of a public-private partnership. I mean, increasing computer or smartphone ownership, not just for healthcare, but also for education, as we're seeing, increasing literacy, information technology training, and then expanding broadband availability. So I don't know that it's something that, as an oncologist, and you have a patient who, doesn't have a smartphone or doesn't have an internet access, there's very little that you as an individual physician can do. And I think another divide, and not just the digital divide, but another divide that will have to be bridged in all of this is the divide between healthcare delivery systems and public health, right? Like we've seen that now, a renewed focus on like what the country's state of public health infrastructure is. But I think this now becomes a part of it, which is that health systems are going to have to continue having a conversation with our public health colleagues about issues around the digital divide and getting their support and supporting our patients.
I would say that these practical aspects, we do need to bear in mind that we've been doing in-person medicine for millennia. And it's been an iterative process. I mean, 100 years ago, it was a lot of house calls. Now we're kind of returning to another form of house calls, which has some advantages in that, you can see more of the way a person lives and have their family around, et cetera. The one challenge is that, and you alluded to this, Sam, that in many cases, I think where all of us work, we have a team of people supporting us in the clinic. We have MAs, we have nurses, we have just schedulers, all sorts of people. And the way it's generally been implemented, rush is you do it all. You don't have a team anymore. That's part of why it's not incredibly more time efficient. It is arguably less time efficient because it's now falling to you to do all sorts of things. But that I hope and think will get better as we have a more planned way of doing this rather than just cobbling together the pieces we've got. Yeah. The other thing I would say is, disparities is absolutely a major issue. I think we need to recognize that done poorly or, in a rushed way, we can worsen the disparities that are there. But there's, I would say, potential solutions. I mean, getting an inexpensive device that can link people to this kind of portal could be offered. There's companies that would happily sponsor a program to loan an Amazon Fire or something like that to people and get that availability to people where they just click on an icon and they're at the waiting room. Or various institutions, all of the retail spaces, the strip malls that are now empty, some of that could be turned into telemedicine booth, set or something where people from anywhere could just go, and they don't need to have it at their home, but they wouldn't have to sit outside of their area's, library and use their Wi-Fi. So if we just actually try, I think we can come up with solutions for some of these things to turn these disparities into improvements over the status quo.
Yeah, absolutely. I love that idea.
Yeah.
Well, this has been a really interesting conversation. Sam, thank you so much for joining us today. You can find us on iTunes or wherever you find your podcast content. We hope that you will subscribe and send us comments and feedback to beyondthejournalshow@gmail.com. We thank Mark Lindsay and Talking Speaker for production and distribution support. See you in a couple of weeks with our next guest. Thank you.
Thanks so much for taking the time.